information. Like the basic rule is any short case is to keep it short and simple. The examiner is there to pass you. Unless you want to fail yourself, they are going to pass you. So just stick to the basics. Don't try to say anything fancy, and you're through. So a clinical scenario: the 31-year-old patient, farmer by occupation, he has on and off fever since 11 days, pain and swelling on the left thigh for 1 week. He also has a discharging sinus for 1 week and history of discharge of bony particles from the sinus. So in the short case, there are two formats. One is that the examiner will ask you the diagnosis first and then ask you for the positive history and findings to back up your diagnosis and take it on from there. The second is when you'll be asked to present in short your history findings, then give your diagnosis. So either which ways the examination and history doesn't change. So in this case, the patient developed fever and he noticed the swelling which gradually grew in size and eventually ended up in a discharging wound since the last 5 days. So in history, the important factors to ask for are the pain, the nature of pain, the duration, and the activating and relieving factors. Like in the acute phase of osteomyelitis, before the sinus is formed or there is an abscess, there will be throbbing pain which will also disturb the patient's night sleep. Once the sinus is formed and there is chronic discharge, it may become painless. So the nature of the pain and the duration is an important history. Next is the discharge, the quantity of discharge, whether it is serous, purulent, hematogenous, whether there is history of any bony bits. Certain conditions like Madura foot will have a classical history of black granules that will lead you to a diagnosis. Past history, in the cases of chronic osteomyelitis, there may have been an incidence in childhood, or there may be history of previous surgery which has now led to infection. General conditions like diabetes mellitus or anemia, immunocompromised situations, or any immunosuppressant drugs may also predispose or cause osteomyelitis. So general examination in a short case, if you have the time, you should briefly just assess the vitals, but you are expected mainly to focus on local examination. So in inspection of this case, there was a swelling along the proximal aspect, there was a sinus with the skin adhered, there was a puckered scar. You look for any exposed bone pits, you look for any soft tissue contractures, you look for any deformity of the bones. Palpation, you confirm all your findings of inspection. First you go to local temperature, tenderness, then you assess that the sinus or the scar is adherent. If you can palpate any irregular thickened bone ends, any surgical hardware, if you can palpate, and not to forget the local lymph node examination, because in case of infection, you expect them to be enlarged. Movements of the adjacent joints, very often because of the contractures, may be restricted, should not be missed, should be noted down. Also measurements, in case of previous surgeries, there may be shortening. So then you need to measure the true and apparent shortenings. Then after that, you come to a provisional diagnosis, and then you need to be ready with the answer for what investigations you would like to do. Because more often than not, once you present your diagnosis and the examiner asks you what would you like to do next, you directly jump onto the surgery and the surgical plan. So you have to consciously remember that you have not even seen the X-ray of this patient, and how can you suggest surgery. So blood workup, hemogram, the total counts may be marginally raised, ESR, CRP may be raised in chronic osteomyelitis. Should remember to do a blood sugar random. X-ray, of course, is the basis. A sinogram can help. You should know what dye one uses in a sinogram. If you say sinogram and you don't know omnipath is used, then the examiner will think you're bluffing him or you haven't seen any cases of osteomyelitis. Beyond this, I think it depends on the examiner and the scenario in which you're working: bone scan, CT scan, MRI. can be optional investigations depending on the setup where you are. A biopsy sometimes in the absence of a discharging wound can help to differentiate between a neoplastic or a osteomyelitis condition. So this is a classical X-ray of osteomyelitis. There are certain classical findings in any case of chronic osteomyelitis. Two of them are labeled here, that is the sequestrum and the cloaca. Along with that, there is also new bone formation called the involucrum, and there are ill-defined areas of destruction and remodeling with irregular cortical thickening. And there is a loss of corticomedullary differentiation. So certain conditions which can mimic chronic osteomyelitis, of course, when there is a discharging sinus, it kind of becomes a diagnosis of inspection, but you should not get carried away and not give a second thought. There may be a neoplastic condition which has got ulcerated or developed a sinus, and so you should keep that in mind and try and rule out all these during examination. So how you present your diagnosis is also very critical, because if you give unnecessary details, 31-year-old farmer operated first in 10 years back, last 10 months back, that kind of drives the examiner's attention from the point. So keep it brief, yet don't miss out any important findings that may have a role to play in your management. So for this case, the ideal treatment would be surgical, in which the steps would involve debridement of the wound as well as a sequestrectomy, a saucerization, that is de-roofing of the medullary canal and excision of the sinus tract. Broadly, the treatment principles for any case of chronic osteomyelitis include thorough debridement, stabilization of the bone if there is an impending fracture or a pathological fracture. Intraoperative cultures are critical to decide the long-term antibiotics that you're going to give. Please do not mention wound cultures. They do not have much role except for giving you commensals and unnecessarily wasting antibiotics and the patient's expenses. Dead space management, now we can use calcium sulfate or stimulant, which can also act as a delivery for local antibiotics. Soft tissue cover in case of a larger wound, and like I said, systemic antibiotics. So this is a brief case simulation of a case of chronic osteomyelitis, which is probably one of the most common cases